Thank you, Heidi. And hello, everybody. Thank you very much for tuning in this pandemic situation we're in right now. It's this is new for me. So this, but I do love speaking. So I am very excited to give this talk about exotic pet antimicrobial use in the age of antibiotic resistance. Let's see, before I get started, at the end of the presentation, we will be taking some questions. So if you have questions you want to ask, write them down. If you have follow-up questions you want to email me, that's totally cool. My email address, I didn't write it down on any of the slides, but it is, it's my first and last name scrunched together, Andrew Bean, at AERCMN.com. Feel free to email me. I love to work with people and collaborate, and it's fun. So we're going to be talking about antimicrobial use. So, oh, okay, I need to do the thing. There we go. Okay.
And now you can do here.
Okay. But okay, just
Not
the
there.
just the
Down
arrow. Okay. Okay.
You gotta click here, I guess.
All right. Bean's getting himself together. Okay, the current situation we are in is that antimicrobial resistance is a major public health crisis. So just to kind of bring you in on, okay, here's everything that's going on. In the USA, this is pretty new data. This is, or these are pretty new data. A report that was released by the CDC last year. In the USA, at least 2.8 million people are sickened by antibiotic-resistant infections each year. Now, of these people, an estimated 36,000 of them are going to die. In the USA, so just the US, no other countries, each year. That's a pretty big deal. So let me put that in some perspective for you. In the US, I pulled up some other figures. So deaths from automobile accidents, about 39,000. So recall that that we're dealing with about 36,000 deaths from antimicrobial resistant infections. Deaths from automobile accidents, 39,000. That's pretty close. Deaths from influenza, slightly less than that, 34,000. Deaths from gun-related injuries, that's something that's been in the news a fair amount, still about the same, 39, 40,000. So now to put this in like kind of the big perspective, number one cause of mortality in the United States, heart disease. So how many people does heart disease kill every year? Well, a lot, like 20 times as many as antimicrobial resistant infections. So we're not up there yet, but that's, we're talking about tens of thousands of people nonetheless. And then more germane to our profession, unfortunately, deaths from suicide. This is all citizens of the United States, not just veterinarians, but 47,000. So those are some numbers to kind of put things in perspective. These antimicrobial resistance in human medicine causes many deaths, not like heart disease deaths, but still a substantial number. Oh, and yep, so just for I did put that in there too. So it's about as much as influenza, automobile accidents. So antibiotic-associated dysbiosis is also a thing. So Clostridioides difficile. So that used to be Clostridium difficile, now it's Clostridioides. Don't ask me why they changed it. It's based on genetic analysis. I know that much. So these cases are associated with antibiotic use in humans. And so annually, the number of cases of C. diff in the US are about 223,000. Deaths per year, about 13,000. So let's let's add this up. So we got deaths from antibiotic resistance infections, about 35,900. I'll use actual numbers here. Then we get deaths from C. diff infections, 12,800. Add those together. 48,700 from deaths related to antibiotic resistance or antibiotic misuse. And we tend to think of antibiotics as relatively benign. Well, let's just give it an antibiotic. See if that helps. Antibiotics are not benign, and they can result in this sort of thing happening. So we'll talk about that a little bit more later. But this is one of the big reasons why, to me, I'm very passionate about the subject of antimicrobial resistance. So the bald-faced truth of the situation. This is from that report from the CDC. Stop referring to a coming post-antibiotic era. It is already here. You and I are living in a time when some miracle drugs no longer perform miracles, and families are being ripped apart by a microscopic enemy. The time for action is now, and we can be part of the solution. This is in contrast to I don't know how many of y'all have read the James Herriot books. For me, those are the books that got me into veterinary medicine. If you have not read them, these are stories, autobiographical stories by a mixed animal vet in rural Yorkshire, England, who practiced from the 30s through the 70s. And there is one story in All Things Bright and Beautiful, where he talks about the first time that he administered antibiotics to some cows that he was expecting were just going to die, so these I believe it was a sulfonamide that he was using, and the turnaround was, from his perspective at the time, nothing short of miraculous. He was expecting all of the affected cows to die, and all of them survived. And that was a miracle. You and I are now living in a time when some miracle drugs no longer perform miracles. That is really profound. We have come there is such a difference between that of the antimicrobials just working every time, and now we have to deal with such widespread resistance. It's really scary. So now, when you talk about antimicrobial resistance is an ecological problem. I want to show you a picture of that illustrates what I'm talking about. We have a whole, so antimicrobials come into the environment from all sorts of different sources. They accumulate in various sources. And so this really becomes, it's not just a matter of a single patient or a group of patients in a hospital, but these antibiotics got to go somewhere. You think about when, so you give an antibiotic to an animal to, say, treat bacterial cystitis. In order to treat that cystitis, that antibiotic is being excreted in the urine, so it can get to therapeutic concentrations in the urine. And this is a like active unbound drug here. And so it's in the urine, great. That antibiotic gets peed out. And that goes into the environment, and there are tons of bacteria everywhere, so they're getting exposed to antibiotics through those means. But what this picture illustrates is are the variety of sources and ways that antimicrobials can accumulate. So the big one up here is of course pharmaceutical manufacturing. So that if there are leaks or if things aren't being done up to par, you can get antimicrobials leaching into the environment directly from the facility. then and then over here in this house, that's what I was talking about, how drugs can pass out of the body and excreted unchanged, so not in the urine, but also the stool. So we get so those concentrate in the sewage and then go to the sewage treatment plant. The sewage treatment plant, you know, that may not do much to filter out any drugs or drug metabolites. So that then wastewater is either then accumulates in just in standing bodies of water or groundwater. Landfills are a source of antimicrobials too, antimicrobial waste. Then the landfills can that material can be used as fertilizer. Also over here, you have wildlife that are getting exposed to antimicrobials through ingesting garbage. Animals that live in bodies of water where wastewater accumulates, they can get exposed to the antimicrobials, and it'll accumulate in their tissues too. Up here, little bird who also interacts with the environment here. Of course, in the water, you have fish and other organisms that spend all their time in the water. And then, of course, we also have production animal use of antibiotics. If they're treated, it can be excreted in their urine and feces too, directly into the environment, or if there's a carcass that doesn't get disposed of properly, then you have scavengers that can consume those animals and get exposed that way. Maybe not as common in developed nations as it is in developing nations, but still certainly happens. All right, now how antibiotic resistance spreads. So this is review for a lot of folks, but I think it's important to go through it again because I need to hear things several times over before they really start to sink in. If y'all, any of y'all can just hear it once and remember it, props, but I can't do that. Two major routes here. So antibiotics are dispensed. George gets antibiotics and develops resistant bacteria in his gut. Now, for purposes of this conversation, so we got two sides here. We got antibiotics going to an individual and antibiotics going to production animals. I would suggest that you consider this individual prescription. Consider our pet animals instead, because now there's not a lot of evidence to support animals being major pets being major point sources of resistance, and part of that is because it's a pretty hard thing to research. But I don't think it's a very far stretch to make an analogy between humans and people receiving humans and animals receiving antimicrobials. So George develops a resistant bacteria in his gut. We'll call him George the guinea pig because guinea pigs are cute and awesome. Then George can stay at home and then the general community and spread the resistant bacteria that way. Or George the guinea pig gets admitted to the hospital and exposes other patients there to those bacteria. Resistant germs then can spread to the healthcare workers or other patients, and then we've got this this vicious circle here. The other side of the equation here is we've got production animals getting antimicrobials in large amounts. That those drug-resistant bacteria can then remain on the meat, and then if that meat isn't handled or cooked properly, then we get exposed. Because I have a master's in public health, and even then I try really hard to handle meat and eggs and animal products properly. I'm sure I screw it up. I am absolutely fallible. So no one is perfect. And also, so you can get exposed to antimicrobial resistant bacteria that way. Pardon me. Also, the fertilizer in the water can accumulate in the ground there, and then it's used, and then that can get transferred to food crops, and then people eat those crops. You know, you're supposed to wash your food before you eat it, but I'm not gonna lie. When so we get the big container of cherry tomatoes from Costco, because everybody goes to Costco these days, and you put it out in you put that all those cherry tomatoes in a bowl, and you don't rinse all of the tomatoes at once because that'll make them go bad faster. So I would be lying if I said every time I grabbed a handful of cherry tomatoes, I washed them in the sink. Usually I do it, not all the time. Bad dog. All right. So now how it actually happens, how antibiotic resistance actually happens in the gut. So gut is a huge microbiome, lots of germs, very few are drug resistant. Then you give an antibiotic systemically. This is not a smart bomb we're talking about. That drug is going to spread throughout the body and to most tissue compartments. So bacteria that are exposed to this, if they are not resistant and the concentrations are sufficient to kill them, they will die. Well, now we've got, now all the susceptible bacteria have been killed off, and we've got many more resistant bacteria. In addition, these bacteria are all sharing genetic information, and so the resistance genes can be shared with other bacteria and allow antibiotic resistance to spread. Now, this is a pretty simplified version of how this sort of thing happens. In reality, the antimicrobials and antimicrobial resistance genes, I mean, these genes are all millennia old. They have been around for a long time. There's some evidence actually that bacteria can use these to communicate with each other, not just a kind of a competition, survival of the fittest sort of thing. When you dig into the weeds, it's some really interesting stuff. But here's the basic principle of how it happens. This is what goes on. So now horizontal gene transfer, this step 4 right here, sharing DNA between bacteria. So recall, so bacteria have DNA, they have their DNA, but then there are also plasmids. Plasmids are separate from the bacterial genome, and they contain bits of DNA, not the whole thing. And those plasmids can be shared with other bacteria. How that, now, the various ways that you can have horizontal gene transfer, so transfer between two bacteria from the same generation as opposed to through reproduction. You've got conjugation. So this is what I was talking about with sharing of plasmids. So the bacteria have a sex pilus, a small tube that forms between them, and a plasmid can transfer between the two of them. And this little green chunk in the plasmid right here represents an antibiotic resistance gene. You also have bacteriophages, those things that look kind of look like the face huggers from the Alien movies I always think about, or really weird spiders. But they can infect bacteria, and then through the transfer the transfer of DNA, they can also share antibiotic resistance genes there. And then actual transformation. So bacteria in the environment that die, their DNA is released into the free-floating space there, and bacteria can actually take up that DNA and incorporate it into their chromosome. So that's kind of the overview on how everything works. I'm just going to change my screen there, and we're going to just take a little. We're going to hit the evidence a little bit, just kind of an overview of what's been published and what sort of impacts our antimicrobial use has. So this first study here, this is a pretty small study, but it looked at the impact of routine antibiotic therapy on canine fecal E. coli and the resistance genes that those E. coli then expressed. Like I said, so I mean, it's a pilot study, so it's going to be small. What they did was they took 7 dogs. They gave 2 of them. They gave 2 of them enrofloxacin for a week, 2 of them clavamox for a week, and no, I'm sorry, not 7 dogs, 6 dogs, and 2 of them placebo for a week. And then they looked at their fecal E. coli and what resistance genes were expressed. So what they saw was that both dogs that got antibiotics, their E. coli showed more. Oh, I'm sorry, it's not. I said clavamox. They actually just gave them amoxicillin, not clavamox. But both the E. coli from the dogs that got antibiotic showed more resistance to traits than the dogs that got the placebo. Okay, big surprise. What was additionally concerning was that the dogs that got enrofloxacin, the dogs that got Baytril, those dogs showed resistance to or rather, the E. coli from those dogs showed resistance to much more than just enrofloxacin. So, of course, all the quinolones, but also chloramphenicol, tetracyclines, ampicillin, and rifampin, all from getting a 7-day course of Baytril. Additionally concerning was that so they followed these dogs for 3 weeks after the dogs finished their course of antibiotics. So the dogs that got amoxicillin, the E. coli in their guts reverted back to kind of the wild type without the resistance to amoxicillin within 3 weeks, within the period of study. However, with the dogs that got Baytril, the E. coli from those dogs continued to show the resistance traits through the end of the study. So you give this dog Baytril because maybe it has a pyelonephritis or something like that, and you want to hit it hard. But then think about this dog is then defecating, not just and urinating, not just Baytril into the environment, but its feces has E. coli that with very active resistance to a variety of drugs. Now, and the way that they reasoned that out, how did that happen? How did the Baytril induce such widespread resistance to more than just a quinolone compared to the dogs that got amoxi? Their E. coli really only showed resistance to beta-lactams. The bacteria, there are different mechanisms of resistance, and one of the ways that E. coli can become resistant to fluoroquinolones is through efflux pumps. basically these pumps on the cell membrane of the bacteria that kick out the stuff that's not supposed to be there. And they're not specific to fluoroquinolones. If the efflux pump, the genes that code for efflux pump get activated, they can kick out a variety of antibiotics. So that's bad news from our perspective. Let me just get my notes here. All right. So the follow-up to this to that study, they did the same group of people did a follow-up study with a slightly larger group of dogs. So instead of 2 dogs in each group, they had 8 dogs in each group, and they found similar sorts of things, that that efflux pumps were expressed in E. coli from dogs that got enrofloxacin, and that resulted in resistance to chloramphenicol and tetracyclines as well. I don't recall them saying anything about rifampin or ampicillin or anything like that, but especially with fluoroquinolones, they can induce quite a bit of resistance. Let's see. So, and totally different group did a study too. So this is a much larger study, 127 dogs from 3 different hospitals. Now they looked at a bunch of different drugs. So dogs, let's see, to qualify for the study, they couldn't have had antimicrobial therapy, I think, within the last 3 months. And then, so dogs either got cephalexin, clindamycin, cefavecin, convenia, amoxiclav, clavamox, or a quinolone, either enrofloxacin or marbofloxacin. The treatment duration varied between these treatment groups, so it wasn't a totally controlled setting like the last 2 studies. And what they saw was that E. coli from dogs expressed let's see, E. coli from dogs that got treated with cephalexin, cefavecin, convenia, and clavamox all showed increased prevalence of multi-drug resistance, extended spectrum beta-lactamase. So that's the beta-lactamase that's going to inactivate things like 3rd-generation cephalosporins, and AMP-C. So that's another resistance gene. Fluoroquinolone resistance was seen after treatment, not just with the quinolones, but also with the cephalosporins, and not just convenia. Convenia, you know, we generally talked about as a 3rd-generation cephalosporin. I have heard people talk about it as, you know, not quite a 3rd generation, so I think there's some ambiguity there. But that's a bigger gun cephalosporin than cephalexin. But cephalexin and convenia and enrofloxacin and marbofloxacin resulted in E. coli from dogs showing resistance to quinolones. So, and quinolones, as we all know, are a pretty big gun. Now, and they follow these dogs after their courses of therapy for a while. For almost all the dogs, within a month, the E. coli had reverted back to its wild type. So, in the absence of ongoing selective pressure for the bacteria to express resistance, then their over time the resistance just doesn't get expressed as much, because they don't need it to survive. However, the dogs that were treated with clavamox, not people are using clavamox all the time. If you look at some of the antimicrobial treatment guidelines from the ACVIM, clavamox is often considered a first line for some types of infections. The dogs who were treated with Clavamox still showed the E. coli from dogs who received Clavamox still showed resistance to third-generation cephalosporins a month after treatment. Now, by 3 months, everything had normalized. So, like I said, there is that reversion back to the wild type in the absence of continued selective pressure. But that's pretty concerning that that resistance can persist that long. Other factors that they looked at in their population that were positively associated with the presence of resistant E. coli. So if these factors were associated, there's association is not causation. We're all familiar with that statement, but multi-dog households were more likely to have dogs from a multi-dog household were more likely to have E. coli that had resistance characteristics. Recruitment from a referral center, because we deal with some nasty infections, but that's the thing. Eating other dogs' feces, coprophagia, was associated with having resistant E. coli in the poop. Who'd have thought? And of course, no one can ever figure out how to get the dog to stop eating the poop. My parents' own beagle just has, she's got a nose for poop, and I wonder what the E. coli in her gut is expressing in terms of resistance. Let's see. If there was an owner who worked in a healthcare setting, that was associated with a higher likelihood of antimicrobial resistance in the fecal E. coli. So there's there could be some sharing of resistance genes between owner and pet. A diagnosis of pyoderma was, so if that was the reason that the dog got the antibiotic, then that was associated with having resistant E. coli. My guess is because cephalexin and convenia are often used in the treatment of pyoderma. And large breed dogs were also were more likely to have resistant E. coli. I don't know what that's about. Okay. Let's see. This study here looked at resistance specifically in staph pseudintermedius and its relationship with prior antimicrobial administration in dogs. Sample size, decent size for us in VetMed, 104 dogs. Dogs with recent treatment with beta-lactam antibiotics, so penicillin or cephalosporin, 8.5 times more likely to have methicillin resistance. So this is a retrospective study, so we're talking about odds ratio here. But the odds of a dog having a methicillin resistant staph were 8.5 times higher if the dog had gotten treatment with a beta-lactam. Now, dogs with recent therapy with beta-lactams were also more likely to show fluoroquinolone resistance, or the staph pseud from these dogs, more likely to show resistance to quinolones, especially if it was within the past month. Odds ratio 4.5 times higher. Treatment with fluoroquinolones induced similar levels of resistance for those staph pseud organisms, and multi-drug resistant infections were more likely in dogs who had been administered 2 or more antibiotics recently. So let's see, longer therapies with beta-lactams were more likely to have to show methicillin resistance, but interestingly, not longer therapies with quinolones. So a little yet another data point for us there. Let's see. Now, okay, moving on to cross-species impacts of resistance and studies that have looked at that. I'm going to take us back a couple of decades. This study was published back in 1997. So what happened here? So avaparsin is a drug. It's a glycopeptide used as a growth promoter in pigs and poultry and I don't know if it was used in the U.S., but it was used in Europe. Avaparsin is related to vancomycin, which is another glycopeptide antibiotic. It is used for treatment of resistant enterococcal infections in humans, enterococcus infections. And let's see. So the use of avaparsin, so there was concern because all of a sudden in Europe, they were starting to see a real increase in these enterococcus infections in humans that were resistant to vancomycin. And enterococcus, if you think about those susceptibility profiles that you get back from the lab, you got an enterococcus. They're already naturally susceptible to a lot of drugs like cephalosporins and pretty much any cephalosporins, clindamycin. There's a lot of intrinsic resistance there. So when you start knocking stuff like vancomycin, you can't use that anymore. That's a big deal. This study showed that animals who got treated with avaparsin, and then they compared them to animals that didn't get that same treatment, the enterococcus isolated from these animals was much higher, much more likely to express resistance to vancomycin. So for, let's see, 38% of samples from farms that used avaparsin, 38% of those enterococcus faecium samples were resistant to vancomycin. For farms that did not use avaparsin, only 10% were resistant to vancomycin. Okay, this is a little more recent. Ceftiofur resistance in Salmonella entericus serovar Heidelberg. Just a reminder, when you're talking about Salmonella, it's almost always Salmonella enterica, and then they've got a whole bunch of different serovars. Serovar Heidelberg, serovar St. Paul is actually one of them. So around the time this was published, Ceftiofur was used in the poultry industry in Canada in both eggs and chicks to prevent E. coli infections. But what they found was that chicks who were getting treated with Ceftiofur, the meat from these chicks, they were isolating salmonella from after these animals had grown and been slaughtered. They were isolating salmonella from the meat that was highly resistant to third generation cephalosporins, and so then they stopped Ceftiofur use, and those resistance profiles went away. No longer resistant to third generation cephalosporins. Started the Ceftiofur use back up again. Hey, what do you know? Resistance comes back. Why? And this is a big deal because at the same time, Canada was seeing increasing levels of resistance to what is it? Ceftriaxone, which is not a drug that I've used, but it's a very important drug for treating salmonella, especially in kids and pregnant women. And those changes in resistance kind of temporarily lined up with the changing Ceftiofur use in chickens. Let's see. This now this study here looked at the role of food animals in humans getting infected with E. coli infections that are resistant to extended spectrum cephalosporins. So this is not a primary study, it's a review of the literature, because I think it's important to look at the evidence. We can theorize about these mechanisms of resistance all day long, but if you actually look at the evidence, at the time this was written, which was, this is a pretty, within the last 5 years or so, there's mixed evidence about the role of food animals in humans getting extended spectrum resistance, cephalosporin resistant E. coli infections. The evidence indicates that there is some role, and that poultry is the most likely species to cause transmission, both whole bacterial transfer, so people eating whole bacteria, and then sharing of genetic elements played a role. The quote that I took from the study was that transmission of whole extended spectrum cephalosporin resistant E. coli and extended spectrum cephalosporin resistant genetic elements from poultry to humans probably occurs, but the specific parameters surrounding this, including the magnitude and geographical extent of the problem, remain inadequately understood. So this continues to be an area where study is needed and ongoing. Okay, so that kind of gives you some perspective of the evidence and what we've seen in some of the literature. So now we're going to talk about, like, we need to think of our patients as an ecosystem, because we're not just a collection of eukaryotic cells. We are there are a whole bunch of prokaryotic cells on us too. In fact, probably more prokaryotic cells than eukaryotic cells. And bacteria play an essential role in host homeostasis. And bacteria are neither good nor bad. I think, we have all at some time or another kind of try to break it down for clients in the simplest terms possible. Okay, well, we want to get the bad bacteria, but bacteria are neither good nor bad. They're there, and they pretty much only have one life goal: to reproduce. That's right, bringing back a reference to a late '90s movie. That's Night at the Roxbury for those of you who are maybe that's before your time. So bacteria and disease. The presence of bacteria at a site does not mean they are causing disease at the site. So, for some examples for you, nasal passages have bacteria, oral cavity, gastrointestinal tract, skin, I didn't list that, but of course there are commensal bacteria there. Urinary bladder even, so I didn't always practice in exotic animal medicine. Exclusively, for 8 years practiced in mixed small animal and exotic practice, and so you get like those cats that have the subclinical Enterococcus bacteriuria. There was a time when we would treat them. It's no longer recommended to treat those. So just because you isolate bacteria from a site doesn't mean that those are that they are pathogenic. Disruption of the normal bacterial flora may cause disruption of homeostasis and allow bacteria to cause disease, because through disruption of the normal population, all of a sudden things get thrown out of whack. You can have bacteria move to new areas. It can allow novel bacteria to colonize a site and maybe be more likely to cause disease. Factors influencing homeostasis. This is especially important for exotic animals because let's say the majority of species that we see in exotic practice, especially when we're not talking about mammals, they're not domesticated. So they have very specific requirements that need to be met in order for them for their bodies to function well. And well, we all know in exotic medicine, husbandry is often, inadequate husbandry is often an underlying problem. So environment, temperature, humidity, lighting, substrate, furniture, so when I say furniture, I mean, do they have does a prey animal have places that it can hide? Because it's a prey animal, it's nature's snack on the go. It needs to find shelter. Air quality, that's a big one that can influence homeostasis. Of course, nutrition is huge. Not just food, but water. What's the water source? Where are they getting it? How often is it being changed? And how is it being provided? Is it being provided in a way that is that the animal prefers? I always ask my clients how they offer their water. There is some evidence in rabbits, at least, that they prefer a bowl. Now that that's one population of I think it was laboratory rabbits. They preferred a bowl over a sipper bottle, but that is everyone is different. So I always ask what the animal likes. If they've never tried, I usually advise to offer both for the mammals and see what they prefer. Ferrets, of course, I usually don't tell them to offer a sipper bottle. Exercise and psychological stimulation, that is really important for just having a healthy animal too. So foraging behaviors, having regular human interaction, conspecific interaction if it is a species that likes conspecific interaction. Syrian hamster does not like conspecific interaction. Guinea pigs do like conspecific interaction. So just interaction with their buddies. Birds, of course, most of the pet birds that we see are flock animals. So they either need human interaction or interaction with other birds to just help them help stimulate their brains. Interaction with other pets, that's what that's about. There are those animals that are besties. So there's like one of our technicians here has a chinchilla who is best friends with the dog, and she'll post pictures of the two of them snuggling up, and it's super cute. So those relationships are important. Another thing to remember is antibiotics are not benign. I mentioned this before, but we really need to get away from considering, well, there's probably not any harm to administering an antibiotic. Okay, first of all, the simple act of administering medications is stressful, often for the client as well as the patient. I mean, how many bird owners have you worked with who are like, oh no, I have to medicate it? But even like my bunny patients, not all of them like their medication. With some exceptions. Usually Metacam goes down pretty smooth, maybe trimethoprim sulfa, but otherwise it can be kind of an undertaking. Injections are painful and provide a potential avenue for bacteria to get into sites where they may not, where they shouldn't be. Injections are particularly painful when you're giving IM injections too. Hypersensitivity reactions can be seen, and but because we're dealing with relatively stoic species, that they may not manifest in a way that would be obvious to us or owners, or maybe we just chalk it up to worsening of the disease that we're already treating. Accidental overdoses may occur. How often have have you sent home a drug with instructions to give 0.05 cc's, and then the client calls and said, oh, I gave 0.5 cc's. What's going to happen? So like there are always avenues for accidental overdoses, and idiosyncratic drug reactions can occur. The one that comes to mind for me, it's actually not an antibiotic, but panic fenbendazole can cause. We used to give it out like water to any rabbit that came in with a head tilt, because, well, you know, E. caniculi, it's not going to hurt. Well, it can actually cause bone marrow suppression that may or may not resolve once you discontinue the drug. So, it's a rare reaction, but it's still something that you need to bear in mind. Antibiotics are not benign, and I always stress this to my owners too. Okay, moving on to diagnostic considerations. We're working up a case where infection is suspected. I think Ockham's razor. The simplest explanation is the most likely explanation. Okay, yeah. It's often used as a crutch in veterinary medicine. So like a rat that is having respiratory distress does not always have rat respiratory syndrome. A rabbit that is sneezing does not always have a Pasteurella infection. A guinea pig that has a big lymph node does not always have a Streptococcus infection. You know, so yesterday I saw a hamster for difficulty breathing. You know, and so there, I remember those years ago when maybe like Dysmic hamster. Oh no, if I touch it, it might die. So I'm just going, so it's Dysmic, it's probably got an infection, here's some antibiotic. Well, no, took some x-rays, its heart was huge. We actually did an echo on that hamster, got some really great images, had dilated cardiomyopathy and a big old thrombus in its left auricle. So antibiotics ain't gonna fix that. So I think we really need to remember that, well, we need to remember Hickham's dictum, which one of my externs introduced me to recently, but I like it a lot. Kind of adjusting it for veterinary medicine, the patient may have as many diseases as it damn well pleases. So just remember that, that just because common things happen commonly doesn't mean that that's what's happening in this patient right now. So we really need to do to work up these patients rather than just dispense antibiotics. Thorough review of the husbandry, of course, in exotic medicine is key. What I think about is asking how and when, not just what. I mentioned the water earlier. How is the water offered? Okay, so the bird eats pellets and it eats seeds. How are you offering them? You know, when is the cage cleaned? When does the animal get to go outside? Not just what temperature is it? Well, it's 75. How do you know that? Do you have a thermometer in the cage? Oh yeah, well, you know, but it kind of, like we got one of those stick-on thermometers when we got it, and it just kind of always says the same temperature. Okay, well, we need to go into kind of dig into this and fix some of the husbandry. I use screening tests to localize disease, you know, and CBC, chemistry, and imaging. I mean, this like your patient's sick, so you need to figure out what's going on. I think when I'm when I'm talking to like back in Virginia, I did a lot of consulting for the emergency clinic, and they'd have something come in, and they'd say, "Well, what do I do with this?" Well, you need this sick guinea pig. I always have guinea pigs on the brain because they're really cute. But what do I do with it? Well, you need to do a diagnostic workup, do some blood work, do some imaging. In our exotic patients, well, for birds and reptiles, chemistry may not be as rewarding as it is in dogs and cats, but it can still help you out. Imaging I find very useful. Ultrasound and CT are becoming more common. You can just see, you can find out so much more, especially CT when you're talking about the skull or the thorax in some of these guys. Some interesting cases that I've had have been like an iguana with bilateral mandibular osteomyelitis that when you saw it on the CT, it was banging. But when you saw it, when you looked at the X-ray, you know, you get the radiologist using hedge words like impression of something or other. But no, when you look at the CT, it's right there. Ultrasound, I do a fair amount of ultrasound too, and that it can be really helpful to figure out what the devil is going on. Once you're able to localize the disease using cytology to guide therapy is really useful as an initial step. Direct sampling of the affected sites should be done and can be used to aid in your drug selection. I find gram stains really important, not just diff quick. So like, for example, I just saw a sugar glider the other day with an abscess on its mouth, likely dental related. I expressed the abscess and did a cytology, and you do a diff quick on it, and we got both rods and cocci. Okay, so it's like, wow, I really need to use something kind of broad spectrum. Because usually, because we're used to thinking of rods as gram negative. That's just kind of in our way of thinking. I do a gram stain. Everything is gram positive. So, that enabled me to use a less broad spectrum, a more narrow spectrum drug, which, you know, keeping your spectrum narrow, just kind of targeting your therapy just to that region. Is important. And for those of you who are saying, well, it's dental, why don't you take out the teeth? We're doing it next week. But we did not have time the day that I saw the glider. So let's see. If you're looking at that cytology, the really key thing, which you may or may not see, but it's useful if you do see it, intracellular bacteria. So in the case of this sugar glider, what I saw a lot. So there were gram-positive cocci, gram-positive rods. The intracellular bacteria I was seeing were the cocci. So that kind of keyed me into thinking, okay, that's the pathogen I need to be focusing in on. The quality of the information that you are getting is only as good as the sample. So direct sample sites are ideal, but if you are sampling a contaminated site, you may not get good information. So if you've got a lesion in the oral cavity, it's hard to get a sample that is going to be that isn't going to be contaminated with other stuff. You can try prepping it with first to get out all the contaminants, and then get a deep sample to try and get a good sample. So fecal cytology is another thing that's falling out of favor. You know, we've all done gram stains on birds. If you see birds, people have been doing fecal gram stains. They're the internal medicine specialists, I I don't think they do fecal cytology anymore. You know, maybe a while ago you could look back on, okay, well, certain bacterial morphology, seagulls or Chinese lettering was suggestive of different pathogens, but just because you're seeing that doesn't mean that's the causative agent. So I personally, I do not do fecal gram stains anymore. I find them pretty useless. Now, microbial culture, of course, we're doing this a lot when we suspect infection. Probably not as much as we should, myself included. I always need to improve on my prescribing practices too. Please don't feel like I'm coming down on y'all from on high, like this is the way it should be done. I need to remind myself of this stuff every day too. Let's see, when you're looking at cultures, they may provide good susceptibility information, but also remember that growth rates in these isolates may vary. So for example, E. coli and alpha hemolytic strep grow pretty quickly, whereas Pseudomonas grows very slowly. And so that may impact the results of your culture. You really need to submit that specimen promptly to get good results. I mean, like, I have certainly been in that situation where I submit a UA to IDEX, for example, and there's bacteria in there. And then I say, oh, well, can you culture that for me? And because I don't want to inconvenience the owner to have them come in and get a fresh sample for culture. But what I really should be doing is having a conversation with the owner about, like, well, this if you want to get the most bang for your buck, you're going to be paying that culture fee either way. Come bring Fluffy back in, and we'll get a fresh sample. I'm doing this in all my patients. I have to remind myself, okay, what is best for the patient, not just what is most convenient for the owner. Also, really important is you need to give the microbiologist some kind of context to interpret the results of the culture. Because how many times have you submitted a culture only to get back, well, non-pathogenic bacteria isolated, so susceptibility is not indicated, and you're like, no, dude, I took this out of this gaping wound on the back of the animal. Tell me what it's susceptible to. If I had submitted some background case information along with the sample, rather than just, here it is, what's in there, then the microbiologist would have been like, oh, okay, that makes more sense. It's more of like a novel bacteria that got inoculated into the site. So let's see. Talking more about microbial culture, tissue cultures are generally considered superior to swabs. Only a few of the colony forming units within a swab are going to culture out. And especially when you're talking about anaerobic cultures, the air trapped between the cotton fibers may inhibit anaerobic growth. I talked about minimizing contamination. You can do that by prepping the site, or if you've got crust, you know how the dermatologists, they really want you to lance a pustule or peel up a crust and sample that rather than just rubbing the slide on the skin willy-nilly. That's really important. Necrotic material and pus is generally inferior to infected but viable tissue. This is especially the case with rabbit and rodent abscesses. That's the thing. So like you want to get a piece of the abscess capsule for culture, or even the entire abscess, rather than just stick a swab in the middle of it. So really what I've taken to do is, if I can get a chunk of tissue rather than a swab, I'm going to do that every time. PCR is the thing too. So so you can do like if you're dealing with you can do PCR for specific bacteria, or what can be useful is some labs will they'll do a PCR of the 16S component of the 30S bacterial ribosome. This allows the actual bacteria to be determined. Now, the lab you use does matter here. There are lots of different labs offer PCR, but we're talking about quality here, and price generally varies too. So there's some labs that offer really cheap PCR, but what protocols are they using? Have they been published? Are they what sort of quality control are they using, and how are the samples being handled? Go back to that statement. The information you get is only as good as the quality of the sample that you submit, and also the quality of the testing that's done. Also, sequencing can be used for confirmation. So one of the labs that I like to use is University of Florida Zoological infectious disease lab, because now their PCR, it is expensive, but it is really high quality, because they will, you don't just get a PCR positive or negative. If it comes back positive, they're going to sequence the DNA to confirm what is it. So you submit, you've got a snake that you're concerned about Cryptosporidium. You submit a PCR. It's not just Cryptosporidium positive or negative, because maybe that Cryptosporidium positive is Cryptosporidium murus from the prey that it was eating. They're going to sequence it out. It'll tell you Cryptosporidium serpentis, which that is absolutely useful for our purposes. Also, PCR is useful for fastidious organisms that aren't necessarily going to grow readily in culture media. Talking about how the culture is done, broth dilutions versus disc diffusion. Broth dilutions provide an approximate concentration of drug that you need to get in the serum so that you can inhibit growth, whereas disc diffusion just gives you a sensitive, intermediate, or resistant. So isolates that we'll go into this in a little bit, but isolates with a broth dilution that have their sensitivity is below the lowest level, that tells you that they are the least susceptible, whereas those that, oh, it's still susceptible, but the concentration is like a defined number rather than a less than or equal to, that tells you that they've started to develop some resistance. Oh, and let's see, variations of one broth dilution are not really considered significant when you're comparing the different susceptibilities. Multiple isolates may reflect contamination of your site. Concurrent use of antimicrobials can affect result. Case history, like I said earlier, case history should be conveyed to the lab to help interpretation. And higher colony counts may reflect a primary pathogen, but also consider how rapidly the isolate grows. Remember, I said that E. coli and alpha hemolytic strep grow fast, Pseudomonas not so much. If you're doing a tracheal wash and you get back, only a few colonies of Pseudomonas, that still may be significant. Treatment considerations. So now this quote is from the current edition of Mader's Reptile and Amphibian Medicine and Surgery, and I really agree with it. Many veterinarians have the mentality that in exotic species, enrofloxacin is a panacea. The routine use of advanced broad-spectrum antibiotics implies a low level of skill on the part of the clinician. It is our duty to develop appropriate antimicrobial stewardship. Veterinarians should limit antibiotic use to those cases in which their use is warranted. Absolutely, 100%. Straight up. So there are a few different bodies that have put together lists of critical antimicrobials that I just wanted to briefly go over. So critical antimicrobial for human medicine per the WHO. So basically this is going, important is the least important category they have. So then there's highly important, critically important with a high priority, and critically important with the highest priority. So just the lowest priority, nitroimidazoles, like metronidazole, nitrofurantoins. Sometimes we will use nitrofurantoin for treatment of UTIs in dogs and cats. I've never used it in an exotic. Highly important, so amphenicols like chloramphenicol, first and second generation cephalosporins, penicillins, anti-staphylococcal, so that'd be like clavamox. Let's see, sulfonamides, including the potentiated ones, tetracyclines. Okay, now we're getting up into the critically important high priority, things like aminoglycosides, monobactams, lipopeptides, some of the more the burlier penicillins. And then finally, highest priority. I want to call y'all's attention to this because third generation cephalosporins and above. Sorry, the one thing that I didn't list on here that people might be like, where are the quinolones at? Oh, no, they're right here. Highest priority, quinolones. That includes fluoroquinolones. Macrolides too, azithromycin. Azithromycin is actually really important for humans. So you need to keep this in mind. I'm not saying don't use these, but I think about when I prescribe an antimicrobial, how important is this drug in general? How important is it that for this patient to get it? The OIE, the World Organization for Animal Health, OIE is the French abbreviation. I'm not going to try and say it, even though I do speak a little French. But they made their own lists. These are only for food animals. So they are, and they're pretty similar to the WHO's list. And then the only publication of any sort of antimicrobial stewardship tiers in exotic practice has come from University of Georgia Zoological Medicine Service. Steve Divers and Jörg Mayer and the whole team there they put together the 3 different tiers and when they want to use them for use in their species. So first tier, so when do you use them? If there's a severely compromised animal, you need to prevent infection, or you need to give intra-op antibiotics as a first-line therapeutic pending culture and sensitivity, potentiated sulfonamides, tetracyclines, basic penicillins, metronidazole, lincosamides, aminoglycosides. So that was one that it kind of struck me, and because you know, it wasn't all that long ago that I was at the U, and you had to get special permission to use an aminoglycoside. But their reasoning is that it is a relatively narrow spectrum. It's going to hit gram negatives mostly only. So that's why they classified it as a first-line antibiotic. I want to call your attention to this. Third generation cephalosporins like Fortaz, second generation quinolones like Batrol. These are only to be used if sensitivity indicates they should be used. So key points here from all those tables. Enrofloxacin is not a first-line drug. I'm going to drive these points home. Fortaz is not a first-line drug. Acceptable first-line drugs should be relatively narrow spectrum and less likely to result in resistance to critically important antibiotics, like tetracyclines, potentiated sulfonamides. First generation cephalosporins, and some of the studies we looked at earlier, that is could demonstrate, could call that into question. Aminoglycosides for reptiles certainly, and metronidazole. basic penicillins, lincosamides. Enrofloxacin, Baytril is not a first-line drug. Fortaz is not a first-line drug. Baytril is not a first-line drug. Lest I say it again, Baytril is not a first-line drug. It is not acceptable to would you give Baytril to a dog that came into your clinic and had respiratory signs? No, I hope you wouldn't. That Baytril is not a first-line drug in any situation. So talking about routes of administration, topical therapy, we're going to get vastly higher concentrations compared to systemic administration, but penetration is limited. There are opportunities for frequent application, and you can use ophthalmic preparations. Nebulization is a type of topical therapy. Nebulizer, the particles that the nebulizers make need to have a specified size, and they will say so in the manufacturer's specifications. 5 micron particles have been shown to penetrate the lower respiratory tract. So you want to make sure what you're using is good, and you can add antimicrobials to that. Systemic therapy must be carried out, so the drug must be carried to the desired site via the serum. So this is, like we talked about, this results in exposure to many microbes beyond just the target population. And protein binding affects the therapeutic concentration of the drugs. The unbound drug is active, the protein bound is inactive. And that protein binding also affects the clearance and therapeutic concentrations. The big drug that we see that in is Convenia. Convenia in dogs and cats has protein binding is like 98, 99%. Don't use it in an exotic animal. So they have looked at it, researchers have looked at it in some bird species and some non-avian reptile species, and it's like you have to give this stuff like I think for birds it was like you needed to give. I can't remember what species, but it was like you had to give Convenia every hour or something like that. It was ridiculous. So just don't use it unless there are studies supporting it. For systemic therapy, concentrations of unbound drug in the plasma approximately are the same as concentrations that you'll get in well-perfused tissues. So skin, lungs, bone, other major internal organs. Poorly perfused tissues will achieve lower drug concentrations like air sacs, necrotic tissue, or if you have an area of compromised circulation. Systemic therapy, you'll have some fluids get higher concentrations than in plasma, like if a drug is excreted in the urine, it might accumulate there. And tissue barriers may be at issue like prostate, brain, eye, you need, or intracellular, you need more lipophilic drugs. Injectable administration is more likely to get a suitable concentration of drug rather than oral. And remember that when you're dealing with birds and reptiles, they have a renal portal system, and you're dealing, and the non-avian reptiles can also have, they can have some hepatic research shunting through the abdominal vein. You could give the drug in the caudal half of the body, so I just don't. Oral administration, I mean, it's easy, but it can result in highly variable serum levels because of difference in GI anatomy and physiology. Different kinds of food in there can bind up the drug. When you're looking at pharmacokinetic data, they will tell you what concentrations of drug you can achieve in the serum. So this, and then you can compare that to the minimal, to the MIC that you got on your culture, so you can get the proper dose. So the things you look at in these studies, the maximum serum concentration, which is the Cmax, or the area under the curve, which is the total drug exposure over time, usually 24 hours, and the half-life. So like, for instance, here, we got this study from HAVR on marbofloxacin after oral administration in rabbits. The key thing to think here in my crappy highlighting is that the mean area under the curve for the drug, we give two numbers here, 10.5 and 10.9. 10.9 is after a week of administration, or 10 days. So I'm probably going to go with that because it's achieved steady state. And the mean plasma concentration at the end of it all was 2.56. Okay, each of those plus or minus. So then we need to look at what kind of drug are we using. Concentration-dependent drugs versus time-dependent drugs. And that's going to affect how you dose things. Concentration-dependent drugs. What you're going to what you want is for aminoglycosides specifically, you want a maximum serum concentration of drug. That's about 8 to 10 times the MIC. If you're looking at a fluoroquinolone, you can either use that same metric or you can use a ratio of area under the curve to MIC, which should be about 100 to 125. For time-dependent drugs, like beta-lactams, you want the Cmax to be 2 to 4 times the MIC for at least 50% of the dosing interval. More is better. But this often means that you have to give these drugs more frequently. So, so just an example for you here. I did I cultured a sample from a rabbit middle ear. We were doing a PICA-BO, a partial ear canal ablation and bulla osteotomy, on a bunny with otitis media and interna, and it cultured out Pseudomonas. And so, great, I'm up against Pseudomonas, awesome. I'm going to look at, I'm going to look at these quinolones here because in this particular patient, it had some underlying renal dysfunction, so I'm going to shy away from an aminoglycoside. So I'm looking at a quinolone. Marbofloxacin right here, its susceptibility was less than or equal to the lowest broth dilution that they use. So I'm going to pick that. Applying PK data, so that's we know that that is our MIC, less than or equal to 0.5. Based on that study that I threw up there, a rabbit that was getting 5 mg per kg of Marbo PO Q24 was going to let's see, the area under the curve was 10.9. The maximum serum concentration was 2.5. Let's do some ratios here between the MIC, assuming that the MIC is 0.5. So the area under the curve to MIC ratio is 21.8, and we want it to be 100 to 125. This maximum serum concentration to the MIC is only 5.12, and we want it to be 8 to 10. So I need to go higher than 5 mg per kg. This is why having pharmacokinetic data is so important, because I wish I had data on like higher doses in rabbits. I don't. So in this case, what I did is I went with the serum to MIC ratio. I doubled the dose to 10 mg per kg. Talking with clients, so a lot of folks are saying, yeah, this is great for y'all in private or in referral practice, but ain't nobody wanting to culture, you know, their hamster. I think it's important that we make these recommendations regardless of the species. And when you're talking about it with your clients, they are well aware of the problem of antibiotic resistance. So they hear it at home, they hear it on the television, they hear it on the radio. So they understand that essential need to determine the right drug, and maybe they have a family member that has gotten an adverse reaction from a drug, so they know what, so they understand why it's important to do these testing. How do we improve antimicrobial stewardship for exotics? This sculpture right here is entitled Waiting, because a lot of us just need to do some waiting. We need more PK and PD studies out there. There really aren't very many for exotics. They are being published more and more, but we need more. And the Clinical Laboratory Standards Institute, those are the guys that determine the breakpoints, that the concentrations of drug that determine whether a bacteria is susceptible or resistant to a drug. Those breakpoints don't exist for exotics. Well, they exist for fish, for aquaculture, but they don't even exist for poultry. So we really need to get this information out there so we can use it. You can develop. There need to be regional and clinic-specific antibiograms, summaries of what has been cultured and what these bugs are resistant to. Within a defined area, a defined time, and that can be used to guide drug selection. If you have a client that really can't afford to do that culture, then at least you have that perspective of, okay, I know that in my region, this is kind of what's been going around. So at least I can draw upon that knowledge to guide my drug selection. And then this particular study here, this is the last thing I'm going to talk about, this is a human systematic review looking at interventions that have been used to improve antibiotic prescribing by human doctors. What they found was that they are effective and they do not increase patient morbidity and mortality. Enabling interventions may be more effective than restrictive interventions, so like chart audit and feedback, educational meetings and materials, consultations with specialists and reminders, verbal posters, even in their EMR software pop-ups. Restrictive interventions may harm the culture, so it'd be like, hid the formulary, so or ripped out pages from the Batral section so they couldn't use it. Prior approval requirements, automatic stop orders, that can really frustrate people. Some resources, local community initiatives for improving antimicrobial stewardship. Dr. Granick has put together a really good initiative on antimicrobial resistance and stewardship. And then the Minnesota One Health Antibiotic Stewardship Collaborative, that's human and veterinary settings. So that's a good resource as well. And that's about it. And with that, I can take some questions. Hold on, I think we need to bring up some things here. So the question is, do you have any thoughts about glyphosate, a Roundup weed killer ingredient patented by Monsanto as an antibiotic present in grains used in human foods? That's a great question. Yeah, so antibiotics are used in plants too. So so that whole One Health perspective for this, it needs to include non-animal agriculture as well. I think I don't know anything about it. So but my thoughts are that that plant application of antibiotics absolutely is an element of the ecological problem of antimicrobial resistance. And then another question that I have here is, can the neomycin and ampicillin resistance genes incorporated into corn genome with genetic modification or horizontally transfer to gut bacteria? Wow, that's a great question. I don't know. Let's see. So at that point, we're talking about bacteria taking up genetic material from a plant, which I don't know how likely that would be to happen. It's an interesting question, though. I don't have a good answer. Let's see. Let's see. Do I pay attention to CT numbers in PCR testing to guess at the number of organisms? I guess it depends. So like if I'm using a quantitative PCR, then that helps me determine like how significant is the organism that I'm getting that I'm getting a PCR on. So that can be useful, yeah. And then another question is, so is the caudal half of a snake better or worse for antibiotic injection? The answer is worse. You want to inject into the cranial half of the snake in order to avoid any shunting of the drug through the liver kidneys. And then there was someone raised that hand, but I don't know what that. Yeah, so Nancy and then I think I saw Jane raise a hand too. If you want to, and Warren, if you want to go ahead and type your questions, I'd be happy to answer them. Oh, I see. I missed a question there. Does Bacillus thuringiensis toxin in corn, rootworm resistance, genetic modification affect gut bacteria resistance? I think you're asking some fantastic questions that really get at the ecological nature of ecological problem of antibiotic resistance. Unfortunately, I don't know the answer. So, so if y'all have any other questions, I would be happy to answer them via email. My email, just to reiterate it, is Andrew Bean. It's all of my it's my first and last name scrunched together at AERC MN Animal Emergency and Referral Center of Minnesota.com. Andrew Bean at AERCMN.com. And I think that'll do it. All right. Thank you all very much.